Good evening, dear viewers. Indian Medical College welcomes you all to this online class. Dear viewers, in today's session, we have our enthusiastic and energetic speaker, Dr. Asitava Debroy, Professor and Head of Department of Pathology from MGM Medical College with us. He is having plenty of teaching experience behind him. He'll be taking a class on myocardial infarction today. Good evening and welcome, sir. It's an immense pleasure to have you here with us, sir.
Good evening. Hello, everyone.
Dear viewers, if you have any doubts or clarifications, you can please type them in the comment section below. Your queries will be clarified by him at the end of the session. Thank you, sir.
Thank you for the very nice and benevolent introduction. And today's topic is a very important one again from the clinical point of view as well as pathological point of view. So today I'll be discussing about myocardial infarction. So I hope every one of you coming from general pathology by now knows the definition of an infarct. So an infarct, as you all know, it is an area of ischemic necrosis, which is caused by any impairment of vascular supply. Now, like any of you who has followed my previous lecture, I usually like to introduce my lecture with a case, with a clinical case. So let's see how we go about with this chapter or with this lecture with a clinical case. So I've named this case as Dilbar Singh ka Dil ka Daura. Now, Dilbar Singh, a 40-year-old CEO of a famous corporate house, was rushed to the hospital with complaints of chest pain, hypotension, profuse sweating, and tachycardia. So this is how a patient usually presents to you with a Dil ka Daura. Most of you must have seen such kind of patient in Bollywood movies. Now, ECG showed an ST segment elevation, and a laboratory evaluation of the serum cardiac marker showed a raised cardiac troponin I. Now, this is how the patient will present to you. Now, keep this case in mind, and we'll discuss this case at the end of the chapter. Now, what is the pathogenesis of the case? Now, as you already know, an infarct usually it occurs due to impairment of a vascular supply. So here it is usually due to coronary artery occlusion, and following which there is a myocardial response. Now, this coronary artery occlusion can be because of a coronary vascular pathology, or it can be without any coronary vascular pathology. Now, what are the conditions where there is no coronary vascular pathology? The conditions are any vasospasm or any embolus from left atrium in association with any atrial fibrillation, or any vegetations in conditions like infective endocarditis may go and lodge there, causing impairment in vascular supply. Or there may be some ischemia in absence of atherosclerosis, and these causes of ischemia may be vasculitis or any deposits of amyloid, or sometimes in cases of shock. Now, if you see what are the arteries that are mostly involved, if you see here the vascular supply of the heart in the diagram on your right, you see this is the left main stem. Number one is the left main stem coronary artery here, and it divides into the left anterior descending branch and the left circumflex artery and the right coronary artery here. Now, if you look at the incidence, the left anterior descending artery is the most commonly involved in 40 to 50% of the cases, followed by the right coronary artery in 30 to 40% of the cases, and lastly, the circumflex artery in 15 to 20% of the cases. So this is the frequency of involvement of the arteries in myocardial infarction. So if you take a section of these arteries, suppose the left antridescending artery, and this is how you see there is an atheromatous plaque in the vessel causing obstruction or obliteration of the lumen, following which there is impairment in the vascular supply. Now, following this following impairment in the vascular supply, or there is some kind of narrowing of the vascular lumina, there is a myocardial response. And how does the myocardium respond? As soon as the blood supply is compromised, there is decreased supply of oxygen to the myocardium, to the muscles, and since the supply of oxygen is reduced, the aerobic metabolism ceases. And as a result of which, the ATP generation is also reduced. Now, since aerobic metabolism ceases, anaerobic metabolism starts, which causes accumulation of lactic acid. This accumulation of lactic acid will cause loss of contractility of the heart. Now see, these are the sequence of events. First, there is ischemia to the myocardial muscles, as a result of which there is anaerobic glycolysis, so increased accumulation of lactate, which will cause decrease in pH, so that will activate the lysosomal enzymes, followed by disintegration of myocardial proteins, and ultimately cell death and necrosis. Now, this cell death and necrosis will be responsible for chest pain in the patient, and because of this necrosis of the cells, there will be release of certain contents into the blood, which are referred to as biochemical markers. I'll come to it in my subsequent slides, and this will also give rise to some specific ECG changes. So this is how the myocardium in acute myocardial infarction responds. Now, there are some specific time of onset of these key events. So the cessation of aerobic respiration is the first thing to happen, and this occurs within seconds. Then the loss of contractility of the cardiac muscles occurs in less than 2 minutes. Then ATP is reduced to 50% of normal in 10 minutes, and ATP is reduced to 10% of normal in 40 minutes. Then it is followed by irreversible cell injury in 20 to 40 minutes. So you see that if you cannot revive the patient in this time, so it leads to irreversible cell injury. And the microvascular injury occurs in more than 1 hour, I mean after 1 hour. Now, there are some types of myocardial infarct based on the extent of involvement. So based on the extent of involvement, there are two types basically, the subendocardial myocardial infarct and the transmural myocardial infarct. Now, if the necrosis is involving 1/3 to half of the ventricular wall, it is subendocardial myocardial infarct. This is caused by incomplete coronary occlusion, and in ECG, you do not get a ST segment elevation. Whereas, on the other hand, transmural myocardial infarction involves the full thickness of the ventricular wall. It is caused by severe and complete coronary occlusion. So if you see, look at the heart muscle like this. So this is one section of the heart. So if this is 1/3 to half, so this is subendocardial. Whereas if you have full thickness infarction, so this is transmural. So this is subendocardial and this is transmural. So these are the two types of myocardial infarct based on the extent of involvement of the infarct. And in transmural, you will obviously get a ST segment elevation in ECG. Now, this evolution of morphological changes, the reversible injury is within, as I told you, within 0 to 30 minutes. Beyond that, the injury becomes irreversible. And here you do not get any change grossly or microscopically. The only change that is obvious is electron microscopic change. And what are these electron microscopic changes? The changes are relaxation of myofibrils, loss of glycogen, and mitochondrial swelling. So within 30 minutes, the injury is basically reversible, and it is not obvious by our naked eyes or by a light microscope, but only by an electron microscope. And these three are the usual findings. Whereas after 30 minutes, what are the changes that we observe? And these changes are basically irreversible. So 30 minutes to 4 hours, there is usually no gross change. However, in microscopy, you see waviness of fibers at the bottom. From 4 to 12 hours, grossly you see dark mottling of the fibers of the muscle, and microscopically you see just beginning of coagulative necrosis, edema, and hemorrhage. 12 to 24 hours. So here now dark mottling becomes prominent, and in the microscopy you see neutrophils begin to start infiltrating. It starts infiltrating. From 1 to 3 days, this mottling again is it alternates with yellow tan infarct center. And from 3 to 7 days, there are some hyperemic borders along with the mottling. And in microscopy, you see that neutrophils, they start to disintegrate, and it is replaced by macrophages. So there is early infiltration of macrophages. Now remember, all these changes that we observe are usually post-mortem changes. Now, obviously, when a patient comes to you, you do not have the chance to cut open his heart and look at it, what are the injuries that has occurred in his heart. So these changes that are studied, the gross changes and microscopic changes in a myocardial infarction, are obviously in a post-mortem heart. So these are not studied in an ante-mortem heart. So these are morphological changes that have been studied in post-mortem specimen of heart in a patient who has died of myocardial infarction. Now from 7 to 10 days, granulation tissue starts appearing, and after 10 days, up to 14 days, collagen starts getting deposited. And beyond 2 months, there is a deposition of dense collagen scar. So this is how these are the morphological changes that occur in the heart of a myocardial infarct. So usually the morphological changes in the heart are questions that were asked previously. Even 4 or 5 years back. Now, this is not usually a trend to ask the morphological changes in the heart of a myocardial infarct patient in recent years. But then still you can expect sometimes, questions from, morphological changes as well. But nowadays, the main focus is on clinical aspects and how a patient would present to you and the investigative part of a condition. Now, one interesting thing is in a postmortem specimen of heart, how would you, there's a test to identify whether there has actually been, an infarct in the heart. And this test is triphenyl tetrazolium chloride test. So what happens is you take a slice of the heart and you dip it in this dye called TTC. Now, when infarcts are less than 12 hours old, they can be diagnosed with this dye. Now, this dye reacts with LDH, lactate dehydrogenase, present only in living cardiac fibers. Okay, So if LDH is present in living cardiac fibers, so the living area of the tissue will take a brick red color. If you can see in the diagram on your right, so brick red color is taken by the living tissue, living cardiac fibers, whereas the infarcted area or the dead fibers are pale. So this part of the tissue is pale in color. So this part is infarcted area and the rest part is living area. So it proves that this part there has been a myocardial infarction. Now coming to the most important part of the whole thing, the diagnosis. So there are three pillars of diagnosis: clinical symptoms, the ECG changes, and the laboratory findings. And WHO says that the patient is diagnosed with myocardial infarction if 2 or 3 of the following criteria are satisfied. If 2 are satisfied, then it is a probable diagnosis. If all the 3 are present, then it is a definite diagnosis. So what are these 3? First is a clinical history of ischemic type of chest pain lasting for more than 20 minutes. Duration is important, more than 20 minutes. Changes in serial ECG tracings. So in serial ECG tracings, you have to have some changes. I'll talk about these changes. And rise and fall of serum cardiac biomarkers. So these 3 are the important criteria. Let us see one by one. So what are the clinical findings? You will have chest pain, you will have shortness of breath, you will have dyspnea, you will have nausea, vomiting, palpitation, cold and clammy skin, and diaphoresis. Diaphoresis means excessive sweating. Now, what is the classical pain in myocardial infarction? The pain, the chest pain in MI is classical. And how do you describe it? It is central in location and diffuse. It is a squeezing type of pain, lasting for more than 20 minutes, radiates to the jaw, the neck, shoulder, and arm, precipitated by exertion and emotion, and it is relieved by rest and nitrates. And it is associated with breathlessness. Now, in clinics, it is important to distinguish between a cardiac pain and a non-cardiac pain, because to you as clinicians or even as residents working in clinics, you will encounter patients coming to you with chest pain. Now, you have to distinguish this chest pain, whether it's a cardiac pain or a non-cardiac pain. So how will you distinguish? So you see, based on the location, cardiac pain will be central, diffuse, whereas a non-cardiac chest pain is usually peripheral and localized. There will be radiation of cardiac pain to jaw, neck, shoulder, arm, but usually a non-cardiac pain has no radiation, or sometimes, if at all, there is a radiation to some other areas. Cardiac pain is tight, squeezing, choking type of pain, whereas non-cardiac pain is sharp, stabbing, and catching. Precipitation, as I told you, for cardiac pain, it is by exertion and emotion. And non-cardiac pain, it is spontaneous, not related to exertion. Relieving factors, cardiac pain is relieved by rest or by nitrates, and non-cardiac pain is not relieved by rest. Associated features in cardiac pain, you get breathlessness, but in non-cardiac pain, there may be respiratory, gastrointestinal, locomotor, or psychological features. So these are the things that you have to keep in mind when you have to distinguish between a cardiac pain and a non-cardiac pain. So these are the radiations of chest pain in MI. So first of all, you see the pain will be central and diffuse. Then it may radiate to your neck, jaw. Then it may radiate to both the arms, shoulder. It may also radiate to the epigastrium. It may also radiate to your sternal area, shoulder, back. Okay, so these are the areas where your chest pain in MI can radiate. Now this Lemoine sign, what is this sign? The person with a pain in MI will localize the chest pain by clenching his fist over his sternum. So this is usually the patient presents to you or shows you how the pain is bothering him. And this has classically been thought to be predictive of cardiac chest pain. Although a prospective or observational study, uh, it has a poor positive predictive value. But this sign has been, of use in, um, um, getting cases or, selecting cases of myocardial infarction with um, this kind of pain. Coming to the ECG changes. Now, this is the normal ECG, which all of you must be knowing, the PQRST waves. Now, what are the changes in ECG in case of MI? These are the two main changes that occur in MI, the ST segment elevation and the pathological Q waves. Now, for a person to qualify as having a ST segment elevation MI, in addition to reported angina, the ECG must show new ST segment elevation in 2 or more adjacent ECG leads. So, as I told you, that means it has to be present in serial ECG tracings. So, only one ECG showing ST segment elevation will not do. So, it has to be in 2 or more ECG tracings. So you see, this is the normal baseline tracing of ECG, where this is the normal ST segment. And if this is the baseline, you see, this is what is called ST segment elevation. The ST segment is elevated from the normal baseline. Coming to the biochemical markers of myocardial infarction, we also call them serum cardiac markers. Now, there are again two categories of these. One is the cardiac enzymes, the other is cardiac proteins. The cardiac enzymes are total CK, or you have CKMB activity or CKMB mass. Then in the cardiac proteins, you have myoglobin and troponins. Now, what is this total CK? As the name suggests, it is the sum of CKMM, CKMB, and CKBB. Now, it is non-specific because it is the sum of all three. The CKMB, it is more specific than total CK because, see, it is only specific for cardiac muscles. But when compared to troponin, it is less specific. Now, this CKMB, it appears in blood within 4 to 6 hours of the onset of the attack of MI, peaks in 12 to 24 hours, and returns to normal within 2 to 3 days. Advantages are, it is used for early diagnosis of MI and also useful for diagnosis of reinfarction. So these advantages are important, and time of appearances are important, because based on this, you can choose to prescribe the serum cardiac markers, which marker to prescribe and which to not. This will depend on the time of appearance of these markers. So that is why the clinical significance of these markers are important. Disadvantages, it is not used for delayed admission. Suppose a person is admitted to the hospital quite some time after he had his attack. It is not very useful because, you see, it returns to normal within 2 to 3 days. So if a person is admitted to the hospital after 2 days, so this marker will be of no use. Now, what is the CKMB fraction? CKMB fraction is CKMB divided by total CK. So, if CKMB fraction is greater than 2.5%, it is suggestive of myocardial injury. So, this is the dictum. If it is more than 2.5%, it is suggestive of myocardial injury. Coming to the next marker, this is myoglobin. It is a cytosolic protein, as you all know from your physiology knowledge. And it is also not specific for cardiac tissue, as it is also found in skeletal muscle and renal tissue. It appears in blood earlier than the other markers. See, you see it appears within 1 to 4 hours. So it has a high sensitivity, but returns to normal in 24 hours. So again, it is not used for delayed admission cases. So although it appears within 1 hour, you see it returns to normal within 1 day. So if you admit the patient on the next day of your attack, so there is no use of this marker. Coming to cardiac troponins. So now this is very important. You must have heard that many of the times the patients who are admitted with a so-called heart attack are advised a trop T. So these are nothing but the cardiac troponins. So these are protein complex located on the thin filament of striated muscle, consists of 3 subunits: cardiac troponin T, cardiac troponin I, and cardiac troponin C. Now, cardiac troponin I and T are used as biomarkers for myocardial infarction diagnosis. Now, troponins are different from skeletal muscle troponins, so more specific for MI diagnosis. Now, this cardiac troponin I is 100% cardiac specific. Appears in blood within 6 hours after onset of infarction, peaks around 24 hours, disappears from blood after about 1 week. So you see it stays for about 1 week. That is why it is useful for diagnosis, even for delayed admission. So this is the only marker you see which can be used for even in for delayed admission cases. And it is also the prognostic marker. So you can use it as to assess the extent of cardiac damage in cases of MI. So this graph can be used to refer to the rise and fall of serum cardiac markers. If you see here that myoglobin is the earliest marker to rise and the earliest to fall. Next in line is the CKMB. And if you see here, cardiac troponins, they appear late and they are the last to disappear. Okay? So this is again a table to show you the time of initial elevation, time of peak, and the time of return to normal. Here again, this is you can see here that although this just to compare in a tabular form, the CKMB and troponin, the time of initial elevation is almost the same. Okay, but the only difference here is the time of return to normal. So here the important thing is this can be used for delayed admission cases, whereas this cannot be used for delayed admission cases. And troponin I is much more specific than CKMB when you consider the specificity. And this is the earliest marker, myoglobin. See, it appears within 1 hour. And also it is the earliest to disappear also. So if you look at it, the early markers, myoglobin, not specific and does not persist for long period. And definite markers, if you say, troponin, 100% specific, prognostic, and stays longer. So these are the 2 catch points. Earliest myoglobin, definitive and most specific, troponin. Therefore, troponin is the current marker of choice and should be available in all cardiac and emergency centers. And if not, then CKMB mass is the second choice. Now, immediate treatment of myocardial infarction, you can remember this mnemonic MONA. So M for morphine to alleviate the pain, O for oxygen, N for nitroglycerin, and A for aspirin. So these are the things that are immediately required to handle the patient who has come to the emergency. I'll not go into the detail of treatment because that will be dealt with in your medicine classes. But lifestyle modification is very important in order to prevent such attacks. As prevention is better than cure, so lifestyle modification is important. You have to have a proper balanced diet. Physical activity is very important. To quit smoking is important, and recommendations regarding driving, flying, stress management, and sexual intercourse in patients who have already suffered an attack of myocardial infarction are important. Therefore, always physical activity and yoga are important for preventing such attacks of myocardial infarction. So coming back to the case of Dilbar Singh, so the questions associated with this case can be, what is your provisional diagnosis? So the diagnosis is obvious. The diagnosis is a case of acute myocardial infarction. The question can, in the case it was that the laboratory investigation found a raised serum cardiac troponin I. Now the question can be, what other cardiac markers are used for diagnosis of this condition? So other cardiac markers can be CKMB, mass, or we can use a CKMB fraction. Then we can use the myoglobins. We can use cardiac troponins, other cardiac troponins like cardiac troponin T. And what is their clinical significance? So there we have to write about the time of appearance and time of disappearance of these clinical, serum cardiac markers, and which one is the most useful, which is the most specific, and which is the most which can be used for delayed admission cases, and which is the most specific of all the markers. The next question can be, describe in brief the etiopathogenesis of the condition, where we can write about what we had talked about, the coronary vascular pathology and about the myocardial response to that coronary vascular occlusion due to atherosclerosis. So the main thing is atherosclerotic plaque blocking the coronary vascular lumen, following which there is a myocardial response leading to this myocardial infarct. So we have the final motto is to keep our heart healthy, fit, and going. So that's all. Thank you.
Sir, have you completed the session?
Yes, I'm done.
Yes, sir. Thank you, sir. Thank you for the wonderful session, sir. And let's wait for a few more minutes for there any queries from the viewers. Dear viewers, okay. Meanwhile, you can like and share our Facebook page to get more latest updates on the schedules, on MCQs, etc. And today we have one more session coming next to this, where Dr. Doraisamy handling a session on A to Z of ECG Part 2. And we have interesting topics in the next day also. Dr. Somasekar handling a session on IMNCI, and Dr. Ramya Ravichandran handling a session on drugs in peptic ulcer. Do stay tuned with this. Dear viewers, you can post your queries here, and you can get it answered later on also. You can see the updates on our Facebook page. Thank you, sir. That's it. There are no queries from the viewers as of now. Thank you for the informative session, sir.
Okay, thanks a lot.